Good day, everyone. Okay, the case I'm going to share with you, I would hope that it's a true convocation, would generate some discussion. So I'll start right to the case. The case is about a 53-year-old gentleman who described himself as previously healthy. He's physically inactive and overweight, like I guess most of us. He complained of intermittent exertional chest pain for almost 2 months, but he mentioned that the day of presentation got more frequent and worse, and for almost 2 hours prior to presentation, his pain got steady, for which he presented to emergency. Now, afterwards, basically, we'll know that the guy had diabetes and dyslipidemia, which was unrecognized. His EKG showed sinus rhythm with extensive anterior STEMI. He was started on our protocol, aspirin, ticagrelor, unfractionated emergency. Cath lab team was called in, and we saw a routine to go radial, so elected for 6 French right radial approach. Okay, so we started with the right, initially diagnostic. It went fine, no issues. I went after doing the right with the extra backup 3.5 guide, and I noticed actually that my J-tip wire was not advancing. So I stopped and I took this picture.
You haven't taken any pictures as of yet?
No, I did the right. So the right had minimal disease. And this is the guide for the left. The guy has anterior MI, so I expected that his LAD is occluded. So I quickly shot the right and went in with the guide. So this is extra backup 3.5 guide that I could not push it forward, so I stopped and I took this injection. And you can see that he has dissection ahead of me.
Okay, so I guess the question to the panel here is that at this point of time, this is obviously a STEMI, time is muscle, and the guider is obviously more stiff, it's not going through, and then you can see something there, probably a dissection in the subclavian distal. So I don't know how many of the panel here are radialists, dedicated radialists. Dr. Samih? Okay, myself, I guess. So for the femoralist, clearly the options here are quite clear, isn't it? What would you do, Dr. Al-Majid, in this case? You've started out with a radial approach.
Yes, I will change the strategy.
You would switch?
Yeah.
Dr. Ramzi? You would switch? Dr. Ahmed? You would switch. What would be the advantage of switching at this point of time? I mean, why would you switch?
I'll try basically just to open his STEMI first, and then I will look after this later on. I mean, I need just to restore his MI first.
So remember that he actually he was able to get the wire down to the descending aorta, inject the right. So he was successful in going down. Now there's a dissection. Obviously the issues here are whether you potentially might make this worse by trying to manipulate the wire and go down and worsen the situation and create 2 problems instead of 1, versus trying to actually track again and try and avoid that dissected area and go to the ascending aorta. So anybody here from the audience would continue with the radial? Who would actually continue? Okay, who would switch? So the vast majority would switch. I think that the issue here is quite, Dr. Hamed, do you do radial for all your cases or you're selective?
No, actually I'm the default for even STEMI, I go radial.
Radial.
Right radial.
So you're an experienced radialist, but in this particular case, you did not want to actually risk it further.
No, actually, so just to go back to the initial one, I did the right, but the right wasn't straightforward going actually to the ascending aorta. I had actually to get the patient to take multiple deep breaths, okay? But I did not anticipate it's gonna be that difficult to get. But what actually prompted me to take this shot is the fact that I could not advance the wire, so I had to stop. So because of the time is of a great essence in these cases, and the fact that, to tell you the truth, I did not have full exchange wire, and I expect that even engagement of the right or the left rather might be a bit challenging, and not to fiddle with this area, I just decided to go femoral. So I could switch to
So
femoral.
that's a very important consideration here, and that is, at least my preference is to use a long wire, 320 wire, and keep it always there in the ascending aorta instead of actually exchanging back and forth. But how many people use the long 035 wire all the time? How many use the standard 035 wire for radial? So I think this is a clear advantage for the long wire, is that you don't go into the hassle of actually going back and forth. You just keep it there, you anchor it. Once you're down, you don't risk actually going in. Most likely what happened is that at some point maybe the distal catheter was, that the wire was not going beyond that.
We'll get to that. It might actually, I'll just show you for you to explain
Okay,
it.
so let's proceed.
I switched
Can
to...
I ask a question here?
Sorry? Yes.
Omar Gutkin, he can correct me. This is very benign lesion. This is against the flow. However, the time is muscle. I always go, I'm a radialist like you, Hamed, as you know, but in STEMI, I go femoral just to cover the chance of 5 to 10% crossover. And the reason of choosing radial right now is not because this is very tough to treat. No, because radial get rid of all the hassles that it might happen during the cath.
True. I just wanted actually to exercise safety, to tell you the truth. That's why I switched. Okay. So anyways, you can see this is the left, it's proximal occlusion, totally occluded. Then it, from there it was straightforward, 275 by 18. You can see his vessel is diffusely diseased distally. Okay. So patient was pretty much doing well. After that, we finished 2 o'clock in the morning. We did CT in the morning. He was chest pain free, very stable. I don't know if you can see it clearly, but I'll just do a close-up, but we lose some of the resolution. So this is the brachiocephalic as it takes off the aortic arch. You can see about 7 millimeter dissection. You can see it. This is in the sagittal view. This is the axial view. This is a close-up view. You can see it clearly here. Can see the contrast goes into the false lumen. And if you can see, this is a speckle of calcification, and probably that why my wire got stuck to this area, and I think in the rush of doing primary PCI, I pushed it, and it caused the damage. You can see the dissection here. Okay. So I brought him back in follow-up. He had the smooth hospital course. I brought him back after 2 weeks. I repeated the CT of his chest. You can see this is pre, this is post. It's not exactly the same cut, but you can see it healed basically, thrombosed. This is the axial view. You can see the contrast here, and it's thrombosed in this view with complete recovery. So I'll just move on. I need actually 2 minutes to show you. Okay, so quickly, it's although it's very common, uncommon occurrence in the cath lab, but it's been described in multiple series. It could be due to catheter-based procedure, could be because of cardiac surgery, most commonly because of the cannulation and clamping, endovascular treatment for aortic coarctation, or even for aortic aneurysm. It can cause a dissection, peripheral intervention, intra-aortic balloon pump, and more recently, we're seeing actually more and more reports because of TAVI. The most likely cause is basically pushing of the catheter against the aortic wall. This is very classical. Or pushing even the J-tip against resistance, and that's most likely what happened in this case. Retrograde extension from dissection into ascending aorta could happen in PCI cases. Most commonly happens from the right sinus, and it's way more common than the left. And whenever actually you come across these complications, you have to decide early on, because that fact is going to affect actually the way you manage the patient, whether it's antegrade injury or retrograde. In my case, it was retrograde dissection. The incidence is variable based on the series, a small series, but it ranges about 4 in 10,000 diagnostic cases and up to 7.5 cases per 1,000 in cardiac intervention. And in the CTO series, it's actually more than that. It reaches 1% of the cases. Okay. I'm just going to skip this one and just share with you for the sake of the time. This is the largest series up to date. It was published last year from the Registry on Aortic Iatrogenic Dissection. It's a European consortium of multiple centers, 9 European centers. They looked actually at a cohort of over 100,000 procedure between 2000 and 2014, close to 66,000 diagnostic and 41 therapeutic procedures. They identified 74 patients with iatrogenic dissection, and this is pure coronary intervention, which is, I think, very pertinent to us. The incidence in this series is about 1 in 1,000. And again, it's actually not different in terms of approach, whether femoral or radial. The procedure type was most obviously commonly with therapeutic procedures. And the cause of dissection was thought to be due to catheters in 68 of the patient and guide wire in 4 in the patient, and they could not identify the cause in 2 patients. Mortality in this series very lowest was 2 patients. The first one died in hospital, and this patient presented with a STEMI, so it would be difficult to be 100% sure it's a STEMI complication or the dissection, but you add the 2 on top of each other, you get high mortality. The other one died within a month, and they're not quite sure of the death. The rest of them, 3 of them required surgery, and most of those who required surgery had antegrade dissection, okay? And the remainder of this cohort basically had been or were managed conservatively, and all of them had excellent recovery. Median follow-up of all over 4 years, okay? This is one of the example in this series. You can see the extensive dissection from the up the greater curvature of the aorta, which is followed up by CT. You can see complete recovery after a few months. Another nice series basically to those who do lots of CTOs, single Italian center. They looked at their data between 2006 2014, about 1,000 patients who underwent, or cases rather, of CTO underwent PCI, and they had 8 iatrogenic dissection, approaching 1% in terms of incidence, all managed conservatively. 1 patient died after discharge with unclear reason. It could have been anything. And very decent follow-up, over 2 years as well. So just to sum up, the management of those patients is not standardized yet. I did not add data from the German registry, which is, I think the last few years it caused some confusion because they claimed, of course for the sake of time, they claimed that the outcome is closer to the spontaneous dissection. But in this series, basically it's a mixed bag. They had post-surgical, they had post-PCI, they had around 100 cases of just in terms of a straightforward PCI or angiography-related cases, the outcome is excellent. One thing important to just point out before I finish is that you have to decide early on what you want to do. So if you had a patient with dissection of the ascending aorta that compromised the flow to the RCA, you have to stent it, okay? If the dissection occurred from manipulation of the ostium or engagement for diagnostic, whatever, then you have to seal the entry point because the mechanism in this situation is antegrade and it can basically propagate. Emergency surgery for extensive type A dissection, if there's evidence or if there's evidence of propagation. Outcome, complete healing in most cases. If promptly recognized propagation of dissection is rare, that's why it's very convenient. It's if you had it and time is of great essence to you in that situation, just switch to femoral, save time. And rupture in these cases exceedingly rare. I haven't actually come across any cases in the literature. Thank you so much.